So in this section, I am going to talk about the ocular myasthenia gravis. See, myasthenia gravis, you know, you always read in medicine, but there is one important component of this myasthenia gravis, and that is your ocular component. So I thought we can actually talk about the ocular part of the myasthenia gravis, though the majority is covered in your medicine classes. So first try to see what is actually myasthenia, and we will be revising your medicine concepts. So myasthenia gravis is actually a autoimmune disorder, and it is characterized by the weakness and the fatigability of the skeletal muscles. So how I like always teaching is, you should know the catch point. So I think there are three important things. The first thing is that it is a autoimmune disorder. So we have the autoantibodies. Second thing, which is a very important catch point, is the fatigability. And the third important thing is that it involves the skeletal muscles. So that means if I am dealing with the patient who is having some autoimmune disorder which is showing you fatigability and also the involvement of the skeletal muscles, this patient may be a patient of myasthenia gravis. Now, what is the most important thing that I am going to get here? I am going to get the muscle weakness. So this is an important thing. Now, due to the fatigability of the skeletal muscles, I am getting the muscle weakness, because here the problem or the dysfunction is at the level of neuromuscular junction. So basically we have got the autoantibodies which are causing the disruption at the level of neuromuscular junction, and the vast majority of the patients are developing the generalized myasthenia, and they are showing the autoantibodies. So we have got the autoantibody rather mediated disease, that is called as myasthenia gravis. So if you take a look on a normal neuromuscular junction, it is something like this. We have got the synaptic cleft where we have the release of the acetylcholine, and this acetylcholine is actually responsible for the muscle activation, right? Now what is happening in cases of the myasthenia? In the cases of the myasthenia, we are having the autoantibodies to the acetylcholine receptors. So because there is a autoantibody to this acetylcholine receptors, the acetylcholine is not able to act, and therefore activation is not taking place. So this is the main pathology which is going to occur, right? So if you see here, you know, what is the major mechanism of action, how this acetylcholine acts? Normally the acetylcholine continuously binds to the acetylcholine receptors on the motor end plate, and this is the reason why actually muscle contraction sustains. So when we have got the autoantibodies against the acetylcholine receptors, the acetylcholine is not able to actually act on its receptors, and muscle contraction, even though it can take place, actually does not sustain. So I will say basically sustainability is a problem, is the myasthenia gravis. Fatigability, easy fatigability is a problem in myasthenia gravis. The person may be able to do the particular action, but he will not be able to sustain, he will not be able to remain in that state, and that is why fatigability will be there, right? Alright. So let us try to see what are the basic muscles and the symptoms which are involved in the eye. Now, as I told you that it is the skeletal muscles which are involved in the myasthenia gravis. So what are the skeletal muscles of the eye? So these are the levator palpebris superioris, that is the LPS muscle. Then we have the orbicularis oculi, the second muscle, and third is your extraocular muscles. So when I can see the symptoms of the myasthenia gravis are isolated to these muscles, the LPS muscle, the orbicularis oculi muscle and the extraocular muscle, I will say that this is ocular myasthenia gravis. And why it is important? Because about half of the patients, half of all the patients of the myasthenia gravis initially present with the symptoms of ptosis, diplopia, or even both without any signs and symptoms elsewhere. So this means the ocular involvement of myasthenia gravis remains an important tool in the diagnosis of the myasthenia gravis itself. Like I always say that those diseases, especially those chronic diseases, systemic diseases which are having the ocular features, ophthalmology involvement, they are mostly diagnosed by their ocular features. Like one common example is your KF ring in the Wilson's disease. So that is the beauty of ophthalmology, because it is picked up very fast, and many at the places where we have multi-system involvement, and one of the system involvement is eye, is basically involved first, and the ocular features tend to present earlier, and that is why picked up early. Approximately 15% of all the patients with the myasthenia gravis have isolated ocular myasthenia gravis as the only manifestation. So 50% of the patients initially present with ocular features, and 15% of the patient presents as only ocular myasthenia gravis. Now we have got very important things other than this which can differentiate the ocular myasthenia gravis and the generalized myasthenia gravis. So let us take a look on the muscles which are involved in the myasthenia gravis. So this is your levator palpebris superioris. So as you see its name itself, levator means it is helping in the elevation. So palpebris, palpebral, aperture, palpebris is present in the upper eyelid, palpebral conjunctiva. So this is the upper lid, and superioris means superior, it is superiorly. So this means that it is causing the elevation of the eyelid, upper eyelid like this. And how much is normal? Normal is 15 mm. So this is the normal what you can say action of the LPS muscle. It helps in elevation of the upper eyelid by about 15 mm, right? Now here we have nothing to do with the nerve supply. Like I know that LPS muscle, you all know, it is supplied by the third cranial nerve, but actually the problem is not with the nerve supply. Our problem is the neuromuscular junction. Our problem is the neuromuscular junction, and that is why if I am having the drooping of the eyelid, right, then it is due to the involvement of LPS muscle that we study in the third nerve palsy also. But I am not having any problem with the third nerve. This is the problem with the neuromuscular junction which is affecting the muscle. So basically I will have the ptosis here which will be myogenic. This will be coming under the myogenic ptosis and not the neurogenic. It's not the neurogenic ptosis. So this is your first muscle. Then the other muscles which are involved here, they are the different extraocular muscles. You know, we have different extraocular muscles. We have superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. All these muscles are also the skeletal muscles. I think there should not be any problem in which are your extraocular muscles. You know, LPS muscle is also included in the extraocular muscle. Let's have a look here. See, this is your superior rectus. Here we have got inferior rectus. This is medial rectus. This is your this one is your medial rectus, and then we have got this lateral rectus, and then you are seeing this through the trochlea. So this is your superior oblique, and inferiorly we have inferior oblique. So all these muscles are also involved in the myasthenia gravis, and that is the reason why the degree of ophthalmoplegia, the limitation of ocular movements, the eye involvement is also much in the patients of myasthenia gravis. And then we have got the third muscle, which is rather very important in terms of the myasthenia, and that is your orbicularis oculi muscle. Orbicularis oculi muscle has got two parts. It has got a orbital part and a palpebral part. And what is the main action of this muscle? The action is closure of the eyelid. So this basically helps in the closure of the eye, and that is why what do we study in cases of the neuroparalytic paralysis? When we are not able to close the eyelid, there was exposure keratitis. So here even this orbicularis oculi muscle, so muscle which is involved in the elevation of the eyelid, muscle involved in the closure of the eye, and also the muscles which are involved in the movements, extraocular muscles, all three of them are actually involved. Alright. Now we will concentrate on the clinical features. Now you have to understand what is the most important ocular feature of the myasthenia, because very frequently this question comes. So you have to remember that ptosis is actually the most common ocular feature. One of the important MCQs is this, that the ptosis is the most common ocular feature due to the early involvement of the LPS muscle. Yes, then we will get the paresis or the paralysis of the other extraocular muscles. So afterwards I will get the oculomotor paresis. Now, why I am saying oculomotor paresis? Because most of the extraocular muscles are supplied by the oculomotor nerve here. Then some patients will show you the orbicularis oculi weakness. So basically what you have to remember, a important triad. If you have the involvement of the triad, if you have got ptosis, you have oculomotor paresis, and you also have the orbicularis oculi weakness, always think about the myasthenia gravis. So you can take it as a takeaway message. If you have a patient who has ptosis, who have oculomotor paresis, who have involvement of the orbicularis oculi, also take it as a patient of myasthenia gravis. Okay, now coming to the important characteristic features that you are going to get. Very important thing is the fluctuation. Means if you are getting a variable, fluctuating means the variable. If you are getting variable involvement of the muscles, if I am getting variable amount of ptosis in different times of the day, sometime it is 2 mm, sometimes it is 3 mm, sometimes it is less. So this variability of the symptoms is always a characteristic feature of myasthenia. Then second important thing is the fatigability. The muscle weakness that you are getting is fatigable. So more you are using that muscle, more it is going into the weakness. So this means that it will be more in the evening, than the morning hours. That is why it is more in the evening hours in comparison to the morning hours. So this is again, you can say it's a variation, like you used to study the diurnal variation of the IOP. So here also we have a variation. So none of the ptosis other than myasthenia gravis will show you a variability, a fatigability, where it can be more in some hours and less in some hours. So this is very important. Okay, so most of the patients will note that the ocular symptoms are worsening as the day progresses or with the tasks such as driving. So, if you are having maybe normal eyelid or very mild amount of ptosis in the morning, but by the time you are there in the evening hours, it's much more. So, think about the myasthenia gravis then. Patients may report that even they do not have any symptoms while they awake. So, these are the catch points and these are the lines that you have to take note when you are reading the MCQ. The examination may elicit the fatigable levator as well as extraocular muscle weakness. So, that I show you that two things you have to remember. One is the variability and another is the fatigability. So, it can be asymmetric, maybe it is more in one eye and it is less in other eye, asymmetry. Second, it is variable, not the same amount of ptosis may be found over the day hours or the evening hours. And the third is the fatigable. So, you always remember that these three things are again very important. So, one triad was the ptosis, oculomotor paresis and the orbicularis oculi, and the other triad is that you have to look whether the ptosis they are talking about is asymmetric, whether it is variable, whether it is fatigable. If you are getting this triad, think about the myasthenia gravis. Alright, now see this. Sometimes what happens that you may confuse this myasthenia gravis, you may confuse it with the INO, that is internuclear ophthalmoplegia. So, how can we differentiate from it? The reason is that the medial rectus is the first muscle, it is the first extraocular muscle to be affected. So, this is again an important point, can be asked as a MCQ also, that in the myasthenia gravis, remember M for M. So, medial rectus involved first in the myasthenia gravis. So, what happens due to the involvement of the medial rectus, there will be adduction deficit and we may be confusing it with the internuclear ophthalmoplegia, but as you know, internuclear ophthalmoplegia will also show the abduction nystagmus. It will also show the abduction nystagmus in the other eye. So, always you can differentiate it from INO on the basis of abduction nystagmus that should be present in cases of the internuclear ophthalmoplegia. There will be no asymmetry, there will be no variability, there will be no fatigability, there will be no involvement of orbicularis oculi muscle, there will be no involvement of the oculomotor paresis, only there is an involvement of the medial rectus and the lateral rectus. So, here again we can have the limitation of this adduction in this eye because of the involvement of the medial rectus, right, but there is no involvement of the other eye, lateral rectus, no abduction nystagmus. So, now another thing, you can also check for the variability and fatigability. Suppose you have asked the patient to look in the upward gaze. So, initially both the eyes are seeing equally, there is no difference, but can you see, I told you sustainability is a problem because muscles have a tendency to go into the fatigue. So, when there is a prolonged upward gaze, the eye will start showing the ptosis. So, this is actually showing what? The fatigability. So, it is showing the fatigability. So, let us talk about the ptosis here, which is an important feature. So, as I told you that the ptosis is often unilateral or it can be bilateral, but then it will be asymmetric on presentation. So, if you are getting the asymmetrical ptosis, variable ptosis, fatigable ptosis, think of myasthenia gravis. A historical pattern of ptosis, a historical pattern of the ptosis which is alternating from one side to the other is again nearly always a sign of myasthenia gravis. So, what you can do? You can compare it with the old photographs of the patient also. Measurements of the eyelid position and the levator palpebrae muscle function using standard methods helps to identify and quantify the weakness. Also, you have to see the fluctuations which are associated with fatigue. So, as I told you again, the three things, asymmetric, variability and fluctuability is very, very important. Now, let us see one more important thing that you are getting due to the involvement of the orbicularis oculi. Let us suppose this patient is seeing in the primary position. Right. So, in the primary position, what you are able to appreciate, can you see here I have more ptosis, here I have less ptosis. So, I can see the asymmetry. So, in the first figure, I am able to see the asymmetry. I am thinking on the lines of the myasthenia gravis. Now, I ask this patient to close the eyelid. I ask the patient for the lid closure. So, initially when the patient is closing the eyelids, there is no problem. But I told you that the problem is the sustainability and the fatigability. So, after some time, the orbicularis oculi muscles get fatigued and they are not able to maintain the eyelids in a closure state, and that is why they will start opening. So, after some time, this is actually initial, right? This is the initial phase, and then after some time when you see in the sustained phase, the eyelids start opening. So, what is this? This is actually called as the eye peak sign. This is called as the eye peak sign. There is a peaking of the eyelids. Can you see here? We have got the peaking of the eyes through the opening of the eyelids, because now the orbicularis oculi muscles are getting fatigued. They are not able to maintain the eyelids in a state of closure. So, this is called as the eye peak sign, and this eye peak sign is actually due to the orbicularis oculi muscle. Right. So, you have to remember again asymmetry, variability, fatigability, orbicularis oculi muscle leading to the eye peak sign. Alright. Now, let us see some other things. So, if you examine for the eyelid fatigue, what are the things that you have to see? If the ptosis fluctuates throughout the examination, if the ptosis is fluctuating, it is changing, it is asymmetrical, in the beginning in one eye it is more, in the one eye it is less, or maybe it is unilateral, and if it is also fluctuating throughout the examination, that means that is showing you the variability or the fatigability of the LPS muscle. Then what are the other things that you can do? Prolonged activation, if you are using LPS muscle, prolonged activation of the LPS muscle can be produced with the sustained up gaze for 1 to 2 minutes. You can ask the patient to look in the up gaze for 1 to 2 minutes, and what will happen? As you ask the patient to maintain the gaze in the superior position, in the elevated phase, using the LPS muscle continuously, will lead to the fatigability of this LPS muscle, and that will lead to the enhancement of the ptosis. That will lead to the enhancement of the ptosis. If the patient is looking continuously in the upward gaze, LPS muscle is used continuously, it will be going into the fatigue, and slowly and gradually drooping will start. This is your fatigability of the LPS muscle. Sometimes what happens, a very important sign is observed. This is called as the Cogan's lid twitch. Suppose you are asking the patient to look in the upward gaze. Okay. So, what is happening? When the patient starts seeing in the upward gaze, there may be rapid fatigue, and the patient's eye is coming back to its position from the upward gaze. It is twitching of the eyelid because of the rapid fatigue of that LPS muscle. This is called as the Cogan's lid twitch sign. When you ask the patient to look in the upward gaze, there is a twitching of the eyelid due to the fatigue of the LPS muscle, called as the Cogan's lid twitch sign. So, see, first we can ask the patient to sustain the down gaze briefly then making a fast eye movement to the upward gaze or a primary gaze. So the affected eyelid will quickly rise and then fall such that the lid appears to twitch. So patient is continuously seeing in the downward gaze, suddenly he will see in the upward gaze. So the affected eyelid will suddenly go up and down. So that looks as if the lid has twitched. This is called as Cogan's lid twitch sign, and you have to remember that this is actually due to the LPS muscle. The eye peak sign is due to the orbicularis oculi, while the Cogan's lid twitch sign is due to the LPS muscle. Similarly, we have got another sign called as the curtaining. Eyelid curtaining occurs. Now what is this? This sign is again very important. It is based on the Haring's law. This sign says that suppose one eye is normal and one eye is ptotic. So if you passively elevate the other eyelid, the same amount of simultaneous and equal innervation to go to its yoke muscle in the affected eyelid also. So if I am elevating this eyelid, that same amount of innervation will go to this ptotic eyelid also, but because this muscle is affected, there is a fatigability, right? So slowly it will start coming down and there will be more ptosis in this eye. So that is called as the curtaining effect. It occurs when more ptotic eyelid. So when more ptotic eyelid is passively lifted above the iris by the examiner and the contralateral eyelid becomes more ptotic by slowly curtaining. So if you are actually elevating the other eyelid, the ptotic eyelid becomes more ptotic. That is actually the curtaining, and this is actually based on the Haring's law of equal and simultaneous innervation. Right. Then we come to the rest test. Rest test means we are seeing the signs of fatigability. Now we are asking the patient to looking for the signs of improvement if I am giving the rest. If it is getting fatigued by more amount of work, it should also improve by the rest. So what I can do, I can actually look for the improvement in the baseline ptosis after having the patient gently close his eyes for about 2 to 5 minutes. Ask the patient to gently close the eyelids for 2 to 5 minutes, and after that you will see that there will be an improvement in the ptosis. Next I am coming to the diplopia. Now though diplopia is less common in comparison to the ptosis, but yes, it could be there because we have the involvement of the extraocular muscles. So we have the binocular diplopia, a prominent feature whenever there is a ophthalmoparesis. Whenever there is an involvement of the extraocular muscles, I can get the ophthalmoparesis. Now this can be multiple, it can be individual, it can be bilateral, it can be unilateral, and you know, for the most of the patients, they have usually first involvement of medial rectus and the lateral rectus muscle. So here the basically these patients will have the diplopia which is binocular and also horizontal. So if they ask you that which diplopia will occur first, it is actually the horizontal diplopia that will occur first because of the involvement of the medial rectus or the lateral rectus or the both. Alright. Now what they are saying that if superior rectus and inferior rectus or the oblique muscles are also involved, then after some time I can also get the vertical component of the diplopia, but the horizontal diplopia is usually first to get occurred because of the first involvement of the medial rectus or the lateral rectus. Virtually every ocular motility disorder, including the associated with the isolated nerve palsies, even CNS, brainstem, they have been also described, but the most important thing remains your ptosis along with the horizontal diplopia. Now we can look at the differential diagnosis. What are the things that you should keep in mind while we are dealing with the cases of myasthenia gravis? The conditions which are causing the bilateral impairment of both the eyelids, or which are causing the problems of oculomotor nerve involvement, they can be considered in the differential diagnosis of the ocular myasthenia. So it can be a thyroid eye disease, chronic progressive external ophthalmoplegia, muscular dystrophy, that is dystrophica myotonica, as well as the brainstem and the motor cranial pathologies. So basically I can say that before marking the final answer, first consider these 4 things also and then take the final decision. Now in this taking of the final decision, there are certain tests which will help me in making this diagnosis, and we have already taken the history, we have taken the examination, you have seen the asymmetry, variability, fatigability, Cogan's lit twist sign, the peak sign, you have already done this. Then what are the things that we can do for the confirmation? So what are the diagnostic tests? So one is your eyes PEC test. I think this is a very interesting test and very effective also. So let us see how this eyes PEC test is done. Now see, this is a patient who is having myasthenia gravis. You can see the ptotic eyelid, you can see the asymmetry. Now we are putting the eyes PEC, and 5 minutes later you will see a magic. See, there is total improvement of the ptosis. So this is how we can see the effectivity of this eyes PEC test. Along with this eyes PEC test, you can also go on with your tensilon test, in which we are injecting the edrophonium, and this edrophonium will again reverse the muscle weakness. So after doing the clinical examination, the history and these 2 tests, we are pretty confident that we are having this case of ocular myasthenia gravis. Then some points related to the medicine, though you may be knowing this, we have to do the serum antibody test. After all, it's a systemic disease. So even if I will make a diagnosis that mine is a case of ocular myasthenia, I'll do a medicine referral, and that physician will actually do all the workup of this patient, the serum antibody titers, then the electrophysiology, repetitive nerve stimulation, the EMG, we will do it, okay. And you have to remember a very important thing, and that is that the single fiber EMG is more sensitive than the repetitive nerve stimulation and may identify the electrophysiological abnormalities in clinically strong muscles, because sometimes what happens that they will actually integrate the ophthalmology and medicine, and along with the Cogan's twist sign and the peaking of the sign, variability, asymmetry and ptosis and all, they will incorporate this one line. So I thought, why not incorporating in my notes only the single fiber EMG is a better test for that. So diagnostic evaluation, the diagnosis of the ocular myasthenia gravis can usually be made, as I told you, with a typical history and ocular examination along with the positive eyes PEC test or the tensilon test. Now further confirmation you can do with the acetylcholine receptor antibodies. If this is negative, what are the other things that we can do? We can do the EMG, and I told you that the single fiber EMG is a better test. If the titer test is positive, then electrophysiology is not needed, right? If the diagnosis remain unclear, then what are the things that you can do? Then we can do a brain MRI and a lumbar puncture. Now, why we are needing this lumbar puncture? We are doing the CSF examination to exclude the other diseases. So basically then the diagnosis becomes a diagnosis of exclusion, and patients with the suspected OMG can also be having the chest CT scan. Now this is again an important point. Why I want to do a chest CT scan? Because I want to rule out the thymoma, and we can also do the thyroid function test in order to rule out the thyroid eye disease, which remains a very important disease in cases of the adults, and it is rather the most common cause of proptosis in the adults. So one thing which will help me in making a diagnosis, which I am not able to make from the clinical examination or history or all these things, that what are the things that you are going to find that there will be no proptosis. So in other cases, when I am having the ophthalmoplegia, right? If I am maybe I am thinking of thyroid eye disease, or I am thinking of chronic progressive external ophthalmoplegia, the cavernous sinus thrombosis, cellulitis or white Lipic syndrome. So these are the things that comes in the mind. So always remember that in those cases we may have proptosis, but here I won't have any proptosis, I won't have any pain, I won't have any paresthesias, right? I don't have the paresthesias, the optic disc congestion, we do not have the optic disc congestion, then we do not have any evidence of infection. We do not have any evidence of infection, like in cases of the cavernous sinus thrombosis or orbital cellulitis. We have the evidence of the maxillary sinusitis, ethmoidal sinusitis. Basically it is the PNS involvement that we usually get in those cases. We get a lot of congestion, then we get a lot of chemosis in those cases, which you are not going to get in these cases, right? And a very important thing is that there will be no pupillary involvement. So in those cases we also have the pupillary involvement, because you know third nerve is the nerve which is involved in the constrictive fibers of the pupillary light reflex pathway. So here we have not the neurogenic, it is the myogenic involvement, and that is why pupillary involvement is not there. This again remains an important catch point. So lastly, the treatment considerations. First we have to go think about the symptomatic as well as immune modulatory treatment, because you know basically it's a auto immune disease. Secondly, you may have to do the thymectomy, and third, what is concerned with respect to the ophthalmology, basically we have to concentrate on the treatment of the ptosis and the strabismus. So what are the takeaway messages? Basically I am not interested in teaching myasthenia gravis as a whole, because it is very beautifully covered in medicine. You know, you people have notes. I want you to concentrate on those aspects of the ocular myasthenia gravis which are found in the other diseases also, and you should be able to differentiate when you are getting a question on ptosis or you are getting a question on ophthalmoplegia. You should be able to differentiate it from the case of a myasthenia gravis. So in that respect you should know that it's an autoimmune disorder, it is involving the neuromuscular junction, autoantibodies against the acetylcholine receptors. Then basically it involves the triad of ptosis, of ophthalmoplegia and the problems in elevation. It has the involvement which is asymmetric, which is variable, which is fatigable, that is there. And what are the eye spec signs, what are your this tensilon test, and actually what are the important things in the investigation that you are going to do once you are have to confirm the diagnosis of myasthenia gravis. So I hope you have understood it, and now you won't be facing the problem in getting the questions of myasthenia gravis. Thank you and happy ophthalmology.